It's a great pleasure to welcome you all in today's webinar, Recent Traits in GI and Lung Cancer. I would like to welcome Dr. Deni Gupta sir. Sir is a senior consultant, medical and hemato-oncology, Dharmshila Narayana Specialty Hospital, Delhi. I would like to welcome Dr. Deni Gupta sir. Sir, please start a welcome note, sir.
Thank you, Garimaji. Thank you. So, hi everyone. I welcome you all to this CME on recent trends in GI and lung cancer. So, let me tell you all of you that this is slightly different in a sense that we all oncologists know that we used to discuss a lot about breast cancer, HER2 positive, triple negative, in different setting, palliative, upfront. And even for the lung cancer, we discussed a lot in stage 4 lung cancer, various type of TKIs. But now I think in recent time data is emerging for GI particularly, excluding the colorectal carcinoma. So we will our CME will be restricted to upper GI basically, and how the data is evolving in GI malignancy in the form of immuno-oncological drug, nivolumab or pembrolizumab and other drugs, because they have shown very good result in the lung and breast and other malignancy. But GI recent data has come up this year, and we should be aware of that so that we can use in our day-to-day routine practice. So our CME is all about this GI newer drugs. Apart from that, second half of this CME will be for the lung cancer. Lung cancer, particularly stage 3 NSCLC, where we were not having any newer drug apart from the chemotherapy. So that area was also unexplored, and newer durvalumab has come into that space. So we'll discuss that Pacific trial in that. And apart from that, small cell lung cancer extensive stage. For that also, we were having only cisplatin etoposide for very long year, many decades. But now we have some of the 2-3 drug IO. So we'll discuss all these things. And apart from this, we'll have 2 sessions on the recent abstract which were published in ESCO. One will be by Dr. Pankaj Goyal about GI. Another will be by me only in the recent abstract about lung cancer. And last but not the least, one will be the session on pathology, but that will be on molecular profiling, a little bit about the TKIs and all that, just to complete the set, by Dr. Richa Nathani from the Lal Lab. So to set the ball rolling, I first of all would invite Dr. Bhuvan Chugh, and he will be delivering the talk on immune checkpoint inhibitor in first line gastric cancer, esophageal gastric, gastroesophageal junction or esophageal adenocarcinoma. So Dr. Bhuvan Chugh, he is consultant, Max Hospital Saket. He is covering Saket and Gurugram and Delhi. So he's in the car, and over to Dr. Bhuvan.
I'm sorry, sir.
No, it's fair enough. Unless until you are driving.
No, I'm not driving. Thank you, sir. It seems like a very exciting program. And so what I'm going to talk about is the use of immuno-oncology in upper GI, which I think it's a very upcoming field there. So I think my slides are visible to everyone if I'm not wrong.
Yes.
So the data which I'm going to present to you is the immune checkpoint inhibitors in the first line setting in the gastric, gastroesophageal junction and adenocarcinoma of the stomach. So we understand that when it comes to the GI tract, or when it comes to the upper GI tract, we have 3 distinct anatomical things. The first is the esophagus, then is the GE junction, and then is the gastric. So what we basically see the difference is that in a patient who is esophageal, we have primarily the tumor is a squamous cell cancer, in which almost half of the patients they express PD-L1, but it's predominantly a squamous cancer. There is the GE junction, in which it's a mix of squamous and adeno, but primarily, rather I would say it's a little more bent towards adeno, but you do see squamous sometimes there, and the boundaries tend to overlap. And then when it comes to the gastric cancer, it's primarily the adenocarcinomas, and the histopathology is very distinct. You end up seeing the standard CA stomach, then you end up seeing these aggressive signet ring cells, then you end up seeing the mucinous varieties, and then you see the lentus plastica types. So there is a variation in the the PD-L1 expression, and it's between 25 to 65%. So disease background, not as common as in Japan, but then we do have our fair share of squamous and we have our fair share of gastroesophageal junction cancers, and primarily there is a there is a good amount of gastric and esophageal being the 6th and the 5th most common cancers in India. And I think what we all understand is there is a high degree of mortality associated with it. And most of our patients, especially the gastric ones, when they present in locally advanced stage, they have a poor 5-year survival. Coming to the risk factors of it, I think it's that the risk factors is almost common to gastric and GE junctions. Other than the H. pylori, which may be protective for the GE junction, is obviously a risk factor for gastric. And there is also alcohol, which is primarily a gastric risk factor as compared to GE. Now, we all understand the TNM classification of gastric cancer. We are all well aware that when it comes to CS stomach, when you do a PET scan, the PET scan may undermine or may underrepresent the nodal positivity. And I think a few of the times when my surgeon colleagues have operated thinking that it's an early stomach, what we end up seeing is that there is a fair amount of lymph nodes present, and then you are not left with anything. So possibly you will have to do a multimodality or a tri-modality treatment in that case, in which you end up doing you obviously have to include radiation because there's a nodal positivity. However, I think in standard early diseases these days, a perioperative, that's FLOT followed by surgery followed by FLOT, is the way to go. So that's what we end up doing in majority of our stomachs, which almost 50% of our stomachs are local regional tumors. The cancers are aggressive. We do know that there is, when it comes to stomach, I think we are all streamlined our approach now. That if it is a GE junction adeno or a stomach adeno, we possibly will start with FLOT and then do surgery and then do FLOT more. And that's what we end up doing most of the times. However, it is these metastatic ones which we in our deep down heart know that they have a median survival of somewhere around 12 to 14 months or 18 months. And that's where you may obviously want to tell the patient that, there is so much more to happen. But then in a stomach, it's primarily the peritoneal disease which tends to happen. There is a early peritoneal spread. There is a drop in the nutrition which tends to happen. Patients tend to lose weight a lot. There's a lot of gastritis. There's a lot of epigastric pain. There's a lot of vomiting, which eventually hits the nutrition. So whenever we are faced with an unresectable or a locally advanced, metastatic CS stomach, I think it's pretty established that if the patient has a poor performance status, has a performance status of 3 or more, it's better to leave them alone. You're probably not going to add much to the life and possibly add morbidity by giving therapy. However, if the patient is fit and if has a patient of PS of equal to 2 or less, then we obviously want to give some degree of cytotoxic chemotherapy plus the targeted therapies in today's world. So with the evolution of trastuzumab deruxtecan and with trastuzumab, I think HER2 has become in 10 to 15% of the patients, they have a HER2 positivity, and then that's where they can be given. And again, we have the PD-L1 coming in such patients, and then PD-L1 can be utilized. So before we move on to the utilization of PD-L1, we all understand that primarily it's a 2-drug cytotoxic regimen. I don't think any one of us is primarily using a 3-drug cytotoxic regimen in a patient who is metastatic, possibly because of toxicity which you possibly add. And at this, you are obviously thinking of how will you take the patient forward rather than reduce the bulk of the disease then. So biomarkers, as I told you, there is basically, it's primarily the immune, the HER2 and the PD-L1. And obviously you have the MSIs basically which says that the tumor is immunogenic or not. So MSI and PD-L1, I think they're suggesting the same thing. And it's the antigenicity of the tumor and the immune profile of the tumor, and then you have HER2. So PD-L1, there is obviously emerging data. The data is somewhere between 25 and 35%. So it will be safe to say that almost 1/3 to 1/4 patient may possibly have a PD-L1 expression. they have a prognostic value that patients who express PD-L1 are associated with inferior OS, inferior overall survival, and they have a predictive value in terms of they may have a higher response rates to the immune checkpoint inhibitors. You understand about HER2 that it's in 10 to 15%, basically around 15% of stomach cancers they have HER2, and that's the patients who we can utilize basically trastuzumab or trastuzumab deruxtecan. However, in this also response rates range in the response rates in the range of around 35 to 40%. So if you add trastuzumab to a GI regimen also, the response rate is somewhere around 40-45% at max. Then is the MSI high tumor. Obviously, we understand that MSI high tumors, they tend to be more immunogenic. However, they do not mean that the patient is going to completely respond to immune checkpoint inhibitors. There is some degree of response rate there. So I think we all are aware of a TPS and a CPS. So what we want to say by TPS is basically the tumor proportion cell, basically the tumor cells which express the PD-L1, and the denominator is same in both, if you can notice. It's the viable tumor cells which are expressing the PD-L1. However, in the CPS, what is difference is that you want to see the tumor environment. The microenvironment of the tumor is important, and that's what it is seen by the CPS. There is how much of the immune cells are picking up the PD-L1. That's what is important in the CPS. And as we go along evolving, as we go along more understanding the immune checkpoint inhibitors, what we realize is it's the interaction with the immune system that is also important. So this is what I meant by interaction. There is a lot of interaction between the T cells and the tumor cells and the dendritic cells. Dendritic cells, we all understand it's basically the antigen presenting cells, how it interacts with the T cell and what macrophages are released. These macrophages, which they can be immune activating macrophages, or they can be immune inactivating or immune silencing macrophages. How they go about and bring a change in the tumor microenvironment, and how they go about killing the tumor cells is what the entire immune biology or immune microenvironment is all about. So the checkmate 649, which is basically gastric cancer, which is adenocarcinoma, GE junction adenocarcinomas, and esophageal adenocarcinoma, however rare they may be, it's the utilization of nivolumab in such setting. So it's a phase 3 trial which compared our standard first line patients of FOLFOX or CAPOX with Opdivo or with nivolumab versus only chemotherapy. The patient had to be untreated previously. They were HER2 negative. They were stratified as PD-L1 positive or negative, and the primary endpoint was OS and PFS in a patient who had a PD-L1 of more than 5%, equal to 5% CPS. The secondary endpoint was anybody who was PD-L1 positive and a PD-L1 of more than equal to 10%. So these were the major side effects. These were the major endpoints. It's a very good design trial, how I would like to say, because they have kind of picked up a CPS point where it is where it is a good patients will be there. So almost 50% of the patients they were around CPS. They had a CPS of more than equal to 5%, and that's almost what it says is that possibly you'll be able to use nivolumab in 1 out of 2 every patient. So the patients were well matched on both the arms, as you expect in a pharma-driven phase 3 trial. And similarly, they had good number of patients who were intestinal, who were diffuse type. There was, we'll come to the MSI high in a bit, but then primarily the baseline characteristics were well matched in both the arms. So was that in a patient who received FOLFOX or plus nivolumab, the 2-year OS rate was around 28% as compared to 19% in the only chemotherapy arm, and that's an all randomized all patients. However, if you look at the patient who was CPS equal to more than 5%, the overall survival was 31% versus 19%, and so I think this is where it gets more interesting, that the PFS, if you look at the PFS values, the patients who had a CPS of around more than equal to 5%, a 2 months advantage in PFS was seen. And so what is to be seen is that all these patients, once you had that advantage, the curves flattened out, and that advantage of around 10% or 8-9%, it's maintained throughout for the next year, 2 years also. So what we are essentially doing by giving immunotherapy is that we're trying to pick up these patients who would end up responding, and they'll continue to do that. So again, the response rates were significantly higher. I would like to focus again on the CPS more than equal to 5%. There's almost 15% increase in the overall response rate. And I think it's pretty encouraging because, whenever you have stomach, that, it's possibly 40 to 45% of your patients will respond. However, if you add immune checkpoint inhibitor, it possibly increases the overall response rate by another 15%. And that's almost 1/3 increase in the response rate. So if you look at 45% response rate and you add more 15% to it, you've increased 25% response rate, or a relative 25% increase in the response rate has happened. And again, the duration of response rate has also improved. So again, coming to the MSI high tumors, so if you look at the overall response rate, it is not 100%. It is 55% in the MSI high tumor. However, in a MSS stable tumor, it's again 59%. So what I would like to bring about here is, when you talk about a MSI high tumor, there's a significant amount of heterogeneity there also. If you possibly have gone through ASCO 2022 presentations, you will possibly understand that all MSI high are not immunogenic. There is certain degree of variability there also. However, what is interesting to see is the people who respond to immune checkpoint inhibitors in MSI high tumors, they tend to have a significantly improved progression-free survival, or improvement in overall survival. So if you have an MSI high tumor, which is obviously less number of patients, around 4 to 5%, the median overall survival is around 38 or 39 months. That's usually around 3.5 years is what we are talking about, or rather 3 years we're talking about, right? Or if you have a OS in a MSS, or a microsatellite stable tumor, it's around 14 months. So that's what it does to you. If you tend to respond in a MSI high setting, you're going to possibly have one of the best outcomes you can have ever imagined. So there's a consistent improvement in overall survival across all the pre-specified subgroups. There is obviously, if you look at the MSI high status, there is a hazard towards death is significantly improved. And I think what I was possibly a little sad to see was that it has not caused much dent in the most difficult to treat stomach, that's the Stegner-Tring cells. It has not caused much of the effect. So why I was a little worried about, because as we get more and more data to use immune checkpoint inhibitors in the neoadjuvant setting, I would want to use such immune checkpoint inhibitor in a neoadjuvant setting along with a FLOT. So there's this data with atezolizumab which has come, in which they have taken atezo plus FLOT and given 4 cycles before and 4 cycles after. However, there was no increase in the surgical morbidity, but then there was some change in the Stegner-Tring cells also. So it's a little difficult. Obviously, you have these subset of patients who have not been doing well, and then you want to do anything and everything for them, and that's where it has not been able to show much yet. But otherwise, in almost all the specified subgroups, there has been a response. And so overall survival in patients with a CPS of less than 1 and less than 5 also, there has not been a significant response. Hence, it has been approved for patients who had a CPS of more than equal to 5. And again, we understand that the response rates are higher, the complete response rates are higher. And I think the duration response is higher. Once you have these set of patients who have been doing well on Hepdiva, possibly you can continue with that, and you can continue for 2 years there. So coming to it, I think most of the patients, they ended up having subsequent lines therapies also, and the predominant subsequent treatment across all these were our standard line of treatment which we use, which is again obviously the oxaliplatin and the taxanes and the platinums. So there were no new safety signals. We all understand how do we manage the immune checkpoint inhibitors. what is really interesting to see is that, as we go on treating more and more immune checkpoint inhibitors, there are obviously more and more safety signals which come in, and obviously we have our learning curves to it. I think I'll try to skip through a little more early because I think we're getting late. So basically what the next few slides want to say is there has been a consistent improvement, or the consistent quality of life has been well maintained across all the specified things. There has been no drop in the quality of life. Most of the patients who took Opdita, they were able to maintain or go through the second line of therapies as they go along. And basically the gist of these slides is that there was no deterioration in the quality of life, and there were no additional signals to suggest that there's a drop in the quality of life. Again, it's the FACT GA and the GA6. There is a EQ-VAS score which says that it was well maintained with the patient who took nivolumab along with it. In short, it means to say that the adverse effects are not significant enough to cause a drop in the quality of life. Similarly, things here, I think, where do we stand is there's an indication, or there's been MDN approval to use Opdita or nivolumab in the first line gastric cancer, gastroesophageal junction, and esophageal adenocarcinoma if you have a CPS of more than 5%. And that's what it is. It is available both for 2 weekly as well as 3 weekly schedules. 2 weekly, obviously, with Folfox, and 3 weekly, obviously, with Capox. There is a 240 and 360 milligrams, respectively, and it is supposed to be given for 24 months. And I think this is my summary slide. It's a first PD-1 inhibitor to improve OS and PFS along with Capox and Folfox in the adenocarcinomas. There's a OS benefit there. There is a higher response rate of around 15% higher response rate. There were no safety signals. The health-related quality of my life measures were all well maintained, and the longer follow-up data will put it as the first line to be used there. Thank you.
Sorry, I was muted. So thank you, Dr. Bhuvan. Very beautifully explained the importance of nivolumab in this setting. I think the point was highlighted that CPS score more than 5. It is well recommended. But if we talk about NCCN, it is category 1. But even for CPS less than 5, they have included as a category 2 indication along with chemotherapy. And apart from that, even for CPS score less than 5, maybe those patients might be having MSI high. So that highlighted the point that we should do both marker together upfront, MSI as well as PDL1, because sometimes we are confused whether we should do both or either alone. So I think this is one setting where both marker will help us deciding in a better way. So with this, next we come to the next talk by Dr. Pankaj Goyal. He is a consultant medical oncology in RGCI Rohini, Delhi. So he'll be discussing about the recent abstract of clinical application GI oncology. I think all of these trial are about colorectal carcinoma. So over to Dr. Pankaj.
And thanks a lot, sir, for giving me this opportunity. So I'll be addressing 6 of these important abstracts dealing with the colorectal carcinoma. And first would be the most exciting one, where we have discussing PD-L1 blockade as curative intent therapy for mismatch repair deficient locally advanced rectal cancer. I think this is the miracle drug, which is at least projected as a miracle drug. So this trial should be known to everyone. So in this, they had taken MMR deficient rectal cancers, which account for 5 to 10% of local cancers, which was either stage 2 or 3. And they had actually randomized them to dostarlimab. And then they have seen whether the patient had residual disease or clinical complete response. If residual disease was there, then this patient needed more of a treatment in the form of chemo-RT. So there were 30 subjects in this, and the primary objective was the overall response rate and PCR. So response criteria they had assessed clinically as well as on MRI to see how deep the response was. So these were the break of this patients. 67% female and 33% male, and T3, T4 lesions were 78, and T1, T2 was 22%. And most of them were node positive, as far as the highest 94%. And if you see the MLH, MSH, and all these status, then 59 patients had positive this MSH, MLH, or PMS2, and 41% had negative. So thereby these patients 67% had high tumor burden. So individual clinical response rate, this is depicted for one patient. They have seen that this was the picture initially, and in the end of the 22 months, this was crystal clear, as we can see visibly. And same can be seen on MRI and PET scan, that hardly any can be seen after the treatment completion. So these patients actually almost all were node positive, as I discussed. 14 of these patients, which were assessed during the follow-up, had complete clinical remission. So this was the exciting result, which was published as we have a ray of hope of curing all patients. So these all patients actually received complete clinical response and complete they were in CR, complete response. This was the duration of response at 6.8 months. All of these patients remained to be in CR at 6.8 months. So 100% complete responses in first consecutive patients, no grade 3-4 adverse events, and no patient required further therapy. However, further therapy is required. And this actually frames a new terminology, immunoablative therapy, seeing the complete response in all the patients. And mismatch repair deficiency population of early stage disease has potential to be cured without any further treatment after this so-called immunoablative therapy. Second was panitumumab plus FOLFOX versus bevacizumab plus FOLFOX in first-line treatment. So initially, this is the paradigm trial. So they had seen what would be the best treatment to be given with FOLFOX in the patients who are RAS wild type. So this we are very well aware that preferably we use EGFR-based therapy, but then they looked into subset of the patients if there any further addition which can be done on the basis of this trial, and the primary endpoint was OS, and left-sided tumors were specifically evaluated, though had taken all the right and left-sided patients. So 411 were allocated, 404 patients in the panitumumab arm, and bevacizumab they were 407 patients. So then this was the baseline patient characteristics. They were well balanced, as we see in all these patients. And left-sided tumors, if we see that in both of the arm, 312 in the left-side population on panitumumab, 292 on bevacizumab, and overall population also appear to be same. And 72% of patients had liver metastasis. And primary endpoint, first we look into the left side population. We see that panitumumab, as expected, did better as compared to bevacizumab in these patients with a hazard ratio of 0.82, p-value 0.031, which was significant. Then they saw in overall population, and they saw that still that holds good, p-value 0.03 and hazard ratio 0.84. But that doesn't mean that you start using in the right side as well. As we see in the left side population, all of these favor panitumumab arm. And if you see in the overall population, again, it seems that panitumumab is doing better than bevacizumab. But if you see the progression-free survival in left side population, it is more or less same. In the overall population, again, the hazard ratio is 1.01. So overall survival was no different. And if we see the left side population here, again, median duration of response was 13.1 months as compared to 11.2 months. And in overall population, 11.9 versus 10.9 months. So this was marginally better in the overall population. Left side population, it was far better. So summary of the adverse events were as expected. With panitumumab, we had these patients who had 17.8% adverse events, and bevacizumab, we had serious adverse events in 10.8%. And subsequent therapies, if the patient has received panitumumab, most of these patients received BEV in second line, and vice versa, the patient who had received BEV received panitumumab in the second line. So now we see the OS in the right-sided population. Till now, it appeared that overall population, left-sided population is doing well with panitumumab. But if we see in the right-sided population, they did not derive any benefit out of panitumumab. In fact, the hazard ratio was 1.09. So unlike whatever we have seen previously, that these patients are detrimental if pushed on panitumumab, the right-sided tumors. In this trial, they say that it did not matter what we are using. So conclusion was left-sided overall survival 37.9 months versus 34.3 months. Overall median survival 36.2 versus 31.2. Although PFS was comparable between two arms, left-sided tumors did better on EGFR-based therapy versus bevacizumab. As we see, the left-sided PFS was 13.7 versus 13.2 months, and overall PFS was 12.9 versus 12 months. So these results support panitumumab as first-line therapy for patients with RAF sites, especially so with the left-sided CRC. Now, another trial is the randomized intermittent versus contiguous panitumumab. So I think this is a welcoming trial because ongoing cost of panitumumab is too much. And we know that after say 4 to 6 months, we derive maximum you say depth of response with panitumumab. So that was a hypothesis whether we can give a panitumumab free gap in between these patients. So this was an improved study. So what they did was in one arm they gave FOLFIRI plus panitumumab for 8 cycles, then treatment-free interval, and in FOLFIRI and another one was continuous. And these were the patients who were treatment naive and they were put on this therapy combination. FOLFIRI with panitumumab intermittent versus continuous. So again, primary endpoint was PFS, and apart from that, secondary endpoints were overall survivals, quality of response, and safety profile. So as I told, these were treatment naive patients, 69 on the continuous arm, 68 in the intermittent arm. And they were well balanced as far as gender is concerned or liver metastasis is concerned, and also the number of metastatic sites. So ongoing treatment in continuous, we had 10 patients who were ongoing treatment at the time of evaluation, while in intermittent, more number of patients were still on treatment, that is 37%. And reason of discontinuation in the continuous FVC is 17% had adverse event because of which the disease, the treatment was discontinued. So if you see the response rate, the disease control rate was more or less same in both the arms, 94% versus 90%. And PFS, if you see the above one, FOLFIRI plus panitumumab intermittent, the median PFS actually seems to be better, 17.1 months as compared to 13.2 months. Intermittent actually led to better tolerability of the treatment and more patients continued on treatment. So why the PFS appears to be better? So according to CIDENDICE, if we see the FOLFIRI plus this panitumumab continuous, 10.7 months in right side as compared to 7.9 months intermittent. So it was no better if we are using the continuous one. But in left side tumors, it did make a difference. As intermittent, the PFS was far better, 20.2 months as compared to 13.2 months. Safety analysis, of course, in the continuous arm, we expect more of these toxicities like skin toxicity as high as 25%. So the primary endpoint has been met with 34 patients alive and without PD at 1 year. In the intermittent arm, that is median PFS of 17.1 months. And this intermittent strategy seemed to be particularly promising for the left-sided tumor, where we see that the PFS was as high as 20.2 months. And it is associated with less skin toxicity and fewer discontinuation rate. OS data is not mature yet, and the result of improved study that take on relevant value of COVID-19 pandemic areas, such as that intermittent therapy would anyway be better and cost effective for these patients. So and another one was the adjuvant chemotherapy guided by CTC. So this was, we know that this is a gray zone in stage 2, which patient should be given therapy as per the guidelines. So they took the CTC analysis, and depending on that, they decided whether the patient should go for a adjuvant therapy or not. So we know that CTC detects minimal residual disease. So it makes a sense that this stage 2 tumors are decided on the basis of the CTC DNA, whether they need adjuvant therapy or not. So they randomize these patients, and few were on the standard management decision for adjuvant therapy, and some patients were put on the ctDNA guided management. And recurrent-free survival was analyzed in these patients. So eligible patients were randomized and had both blood drawn at week 4 and 7 for CTC analysis. And these patients were randomized in either the traditional decision-making, standard management, or the ctDNA-based management. So on the basis of this standard management, more patients needed chemotherapy, 28%. However, with ctDNA-guided therapy, only 15% of the patients were subjected to chemotherapy. So with that, we can see that lesser number of patients required the toxic chemotherapies if the decision is planned on the basis of ctDNA. So here, adjuvant treatment delivery in key subgroups, we see that if any of the high-risk factors is seen, ctDNA-guided therapy favors because less number of patients will be needing that therapy. So recurrence-free survival was all the more same. We see that both the lines are overlapping, 91.7% versus 92.4%. So if we are taking a decision on the basis of ctDNA, this does not lead to any detrimental effect. So recurrence-free survival was more or less same whether you decide in traditional way or the ctDNA based. So recurrence-free survival in the ctDNA positive versus negative. If it is positive, even if you give chemotherapy, the outcome is poorer as compared to the ctDNA free patients who did not get chemotherapy. It was 92.5% in the favorable ctDNA negative, while 86.4% at 36 months in the ctDNA positive subgroup. So these are the recurrence-free survival. We see that the patient is ctDNA negative, then these are the patients who are having the best outcome. We see the top blue lines in both of these. And if the patient is ctDNA positive or patient is high risk according to the traditional criteria, then the outcome of these patients is poorer in these particular patients. So for patients with stage 2 colon cancer, ctDNA guided approach compared to standard of care reduce the proportion of patients needing adjuvant chemotherapy from as high as 28% to 15%. This did not compromise the recurrence-free survival, and patients with a positive ctDNA after surgery may derive recurrence-free survival benefit from adjuvant chemotherapy. So favorable 3-year RFS in patients with adjuvant chemotherapy versus low RFS in histological series if untreated. So there are other ongoing trials which will provide further insight on the optimal usage of ctDNA. So this leads to low recurrence risk without adjuvant chemotherapy if ctDNA is negative. Because 92.5%. So I think this is exciting, and maybe in coming months this will become more or less a standard of care that we will have ctDNA to guide our therapy for the treatment of these patients. With that, I'll conclude, and thanks, Dr. Denny, for involving
me. Thank you, Dr. Pankaj, for enlightening us with so many newer things which is evolving in oncology in such a short span. So starting from the dostarlimab, which is a magic drug, so-called immunoablative therapy, and right-sided versus left-sided colon issue with the newer drug, IO drug, and the ctDNA, role of ctDNA, we will be using in our routine day-to-day practice. So, so next, I would like to invite the next speaker. So we know that from our older days, like I remember my days during MBBS, we were listening that imatinib as a magic drug, and then came the gefitinib as a magic bullet, and so after that we all know that our effort, like and patients with the non-small cell lung cancer stage 4, which were very difficult to treat, and how comfortable our life has been after coming the so many markers, molecular markers, EGFR, ALK, ROS. To set the flavor about all these molecular markers, I would like to invite Dr. Richa Nathani. She is a consultant in Lal Lab, National Reference Laboratory at Rohini. So, ma'am will be delivering a talk on molecular profiling of non-small cell lung cancer. Dr. Richa, over to you.
Thank you so much for the kind introduction, sir. And I would like to thank the organizers for giving me this opportunity. So let's go back to basics. And we will discuss. I hope my screen is visible.
Yes, ma'am. Yes.
Okay, shall we start?
Sure, please.
So topic for today will be molecular profiling of non-small cell carcinoma lung. We all know how much important histology is when it comes to non-small cell carcinoma. Why this histology is important? It is because of the underlying molecular heterogeneity that we see in these adenocarcinomas, which has a wide range of molecular drivers, way different from those in the squamous cell carcinomas that have mainly PIK3CA, FGFR1. But when it comes to adenocarcinomas, we have EGFRs, the most common ones. Back in 2018, CAP had provided guidelines for mustache genes, which included only EGFR, ALK, and ROS1. Then came an expanded panel, which included BRAF, MET, RET, ERBB2, and KRAS. Then came comprehensive panels, which included both mustache genes and the expanded panel. Now, how has this mutation testing in lung cancer evolved? Let's have a look at the NCCN guidelines. Earlier, only 4 molecular markers were mandatory, which were the actionable drivers, the EGFR, ALK, ROS1, BRAF, along with PD-L1. Then in 2020, the list expanded. It added more to it with MET, RET, and ROS1, BRAF also. And this list, because of the targeted therapy available for all these molecular targets, the testing has also increased. Now let us have a look at each one of them. Starting with the most common, that is the EGFR favorite of all, known as the HER1 or ERBB1 also. It is found on the surface epithelium and often overexpressed in a variety of human malignancies apart from lung. It is seen in non-smoker women of Asian descent with adenocarcinoma histology. Patients with pure squamous cells are unlikely to have the sensitizing mutation, while with adenocarcinoma or adenosquamous may have this. TKIs definitely show clinical benefit, but the likelihood of this response is relative to the location of the mutation. The mutation of EGFR usually lies between exon 18 to 21. In exon 18, we have the mutation 719X, 709X, and also the deletion. But the most notorious ones are the commonest ones found are exon 19 deletion or maybe the exon 21 mutation. Apart from them, we come across rare mutations. Now, what are these rare mutations? Exon 20 insertions, L861X, S768I, and many more. So these newer mutations are being disclosed because some of them are responsible for the resistance, like the T790M or the notorious one C797S. Now these mutations, they are responsible for the TKI sensitivity, but also for the resistance. The one in the greens are, yes, a green signal to go ahead, but the resistance mutation, the T761Y in exon 19, and likewise T770 in exon 20, T790M are responsible for the resistance. Now coming to the next common, anaplastic lymphoma kinase, that is the ALK, in ALK gene located on short arm of chromosome 2, encoding receptor tyrosine kinase belonging to insulin receptor superfamily. ALK not only undergoes amplification, but also fusions and mutations, not only in non-small, but also in anaplastic large cell lymphomas, neuroblastomas. It has various fusion partners, but the most common is the EML4 ALK. Frequency in lung cancer is around 4 to 5%, observed in young women with a history of light or never smoking. Now, when this fusion happens, this leads to proliferation and cell survival through various pathways. ROS1, located on chromosome 6 longa, it is a receptor tyrosine kinase involved in various human cancers like gastric, ovarian, cholangio, colorectal, angio, apart from lung. It also has various fusion partners which constitutively activate it and drive the cell proliferation. Seen in around 1% in non-small cell, and also the preclinical evaluation translocation positive shows strong sensitivity to crizotinib. That's how the ALK and the ROS1 fusion, when they are targeted, they are responsible for activation through 3 separate signaling pathways, like the JAK-STAT pathway, the RAS-RAF pathway, and the PIK3-mTOR pathway. Coming to BRAF, a member of RAF family, located in chromosome 7 longa. It has a role in regulating the kinase signaling pathway, which affects cell division, differentiation, and secretion. Yes, the most common V600E, apart from lung, seen in melanomas, non-Hodgkin lymphomas, colorectal, thyroid, and hairy cell. This has been determined to be an activating mutation, the V600E. And the cells that harbor it along with other mutations, they are sensitive to the BRAF inhibitor, dabrafenib, and others. Coming to the KRAS, located on chromosome 12, shorter. It is the Kristin-Rath sarcoma, member of GTB family, responsible for pro-survival signaling. It's most commonly mutated amongst the RAS family in non-small cell. It is frequently observed in smokers, and the incidence in non-smokers around 15%. These mutations usually cluster in the codon 12, 13, and 61, and they dictate a poor prognosis towards when present when compared to the patients without mutation. The mutations are substitution, insertion, or deletions, and they show reduced responsiveness to EGFR TKI. Currently, drug targeting involves combination therapy to circumvent the resistance. Now that's how KRAS functions in a normal cell and a tumor cell. So when we have a wild type KRAS, when a ligand is bound at the membrane, then the downstream signaling pathway is activated. While in a tumor cell, in case of mutant KRAS, which arrests the GTP, and in the absence of the ligand, there is downstream signaling, continuous downstream signaling to the cell nucleus. Coming to the next one, that is MET, located chromosome 7, longa. MET is nothing but mesenchymal to epithelial transition genes, discovered in late 1980s. It also encodes for a receptor tyrosine kinase, which regulates a multitude of cell processes like the cell scattering, invasion, apoptosis, angiogenesis. It is most commonly seen in smokers and older patients and also linked to poor clinical outcome. MET alterations in non-small cell include mutations, exon 14 skipping, which is a targetable gene alteration. It also, this MET skipping, when present, it leads to the loss of CBL binding site. So there is impaired receptor degradation and leading to increased MET signaling. This skipping occurs in around 5% of the non-small cell, seen in both squamous and adenocarcinoma histology. RET, the receptor tyrosine kinase that affects cell proliferation and differentiation. This RET undergoes rearrangement, seen in around 1 to 2% of the non-small cell cancers, and are frequent in patients of adenocarcinoma histology. Now, this rearrangement can be with different partners, most commonly with the kinesin family B, also with coil-coil domain containing C, or NCOI4. The presence of this rearrangement is associated with increased responsiveness to oral RET TKIs, regardless of the fusion partner. The commoner ones, the NTRK123, most commonly seen in the soft tissues, located on chromosome 1, 9, and 15 respectively. They are transmembrane receptor tyrosine kinases having a high affinity for neurotropins and are implicated in neuronal development and differentiation. They are in-frame fusions. They often occur in rare malignancies, but are seen rarely in commonly occurring malignancies. Upon binding by the ligand, like the NGF or others, on the extracellular domain, there occurs phosphorylation of the tyrosine residues and downstream signaling. While in case of the altered TRKs, there can be phosphorylation of the residues independent of the ligand binding. The HER2 or the ERBB2, widely utilized biomarker in breast cancer, which undergoes amplification in 15 to 25% of the cases. However, in non-small cell, it is the mutations that are seen in the exon 20 or the in-frame insertion that we see most commonly. The mutation frequency is definitely lower than the amplification, and the clinical response is also towards the anti-HER2 directed therapy. The MAP2 kinase 1, which is usually considered as a pivotal in resistance to the targeted therapy approaches. MAP2 kinase 1 located on chromosome 15 longa, and it is considered to be mutually exclusive from the known driver mutations. They have a strong association with smoking. Now, after knowing all these molecular drivers, there are certain recommendations and challenges that as a molecular lab we face. The recommendations are the pre-procedural discussions at multidisciplinary lung tumor board. The pathologist should determine the adequacy, prioritizing of the tissue for testing of the actionable oncogenes, and the procedures for quality control and proficiency. Now, what are the challenges? The challenges are the biopsy may not be sufficient, or the diagnosis based on morphological criteria may not be possible with need of IHC to subtype it, and the differing tissue fixatives, processing protocols, storage conditions affecting the sample usually. Under normal circumstances, this is what happens when a tumor biopsy with finite tissue appears to lab. It undergoes histology with more than 2 cancer slides. Then there is subclassification, 1 more slide is gone. So the diagnosis adenocarcinoma, for example, which then undergoes EGFR 5 micron tissue gone. And then we need few more markers, then BRAF, PIK3, FGFR, for example. Then we might need IHC by ALK by IHC, 2 more slides required. If it is equivocal, we require FISH, 2 more slides required there. And then when the patient ends up in the relapse, the pizza that we started with is not left with any. So we feel a need to shift to universal testing platforms. Like the current practices are not sustainable for laboratories, confusing both physicians and regulators. So moving forwards, we recommend one patient, one test. How could that be? So for that, we need to choose the method. Now the method has to be focused on the sensitivity, the time, the money, everything. When you combine all the features, it is the next generation sequencing, which provides you with sensitivity as good as, which can be done on tumor tissue and multiple targets at one time. The test that we see, why NGS? Because it tests many mutations. We can undergo a panel at a time, which is not the case for ddPCR, which is not the case for real-time PCR. Yes, for cheaper, it falls cheaper per mutation. It has a longer TAT, definitely, which is a major drawback, but it can be done for tissue. With in one go, you can cover the entire panel. So we offer customized panel using FISH. We have ALK, ROS1, MET amplification, which is the cancer targeted gene panel. With FISH and NGS Club, we have MET mutation, KRAS, BRAF, ERBB2, and EGFR. Or else we have a 12 gene lung cancer panel, which is with PDL1, SP142 or 263, and covering 12 genes and hotspot genes as well as fusions. Or we have Oncomine Focus Assay, which is 52 genes covering all the hotspots, CNVs, indels, and gene fusions. So this is a recent study of 950 samples that we have done in the past 1 year. Yes, most common being the EGFR, apart from no pathogenic, followed by KRAS and PIK3CA. So my take-home message would be optimal tissue sampling and management is the key to identifying prognostically important genetic subtypes in lung cancer. Individual gene testing is still going on, but we need to graduate to multi-gene testing in view of limited tissue sample. Liquid biopsy, highly sensitive, need no biopsy, but it is single mutation testing. NGS can identify all driving mutations, opening doors to newer therapeutic options and clinical trial scenarios. It is tissue proficient, better half for precision medicine. RNA-based sequencing has overcome most of the shortfalls of existing NGS-based DNA sequencing. And thank you.
Thank you, Dr. Richa, for giving a wonderful talk on various molecular markers in NSCLC. May I ask you one or two questions?
Sure, sir.
Yeah. So just two questions. Like one is you talked about liquid biopsy. So
Yes,
today only I have one patient. So taking that patient as an example, so he came to me as a severe breathlessness patient with on oxygen, and he was carrying a report of a biopsy lung CT guided adenocarcinoma, but sample was not sufficient to carry on further testing. So he was admitted, and someone has advised to go for bronchoscopy, EBUS, biopsy, blah blah blah. So he underwent that, but before that I sent the sample for ddPCR, and I got the report exon 19 deletion. So here are two questions, and EBUS biopsy again sample was not sufficient. In fact, there was no malignancy in that, so that was futile exercises. So there are two questions which I want to ask you. If that patient or any patient, if we don't have the histopathology report of adenocarcinoma, how much comfortable we are in starting the treatment based on ddPCR? That is question
sir,
number one.
yes, sir. Sir, I don't think if the histopath report is unavailable, so we should, wait for the treatment. Yes, EGFR sensitivity is there for ddPCR, so we can start the treatment, in my opinion.
Right. So thankfully, I got the report in 3 days' time from your lab only. Today only I got the report. I was about to start the chemotherapy, but immediately I got the report. It is positive. So another thing like foundation assay, we are sending the sample sometime tissue block, biopsy block sample, and they say that sample is not adequate. So they run the sample, they run the test on blood sample. So how much we can adopt this liquid biopsy sort of thing as a comprehensive panel by NGS, like some of the Indian company are also doing, labs are doing, but I think Lal Lab is not doing on liquid biopsy as a comprehensive NGS. But how much we are comfortable in accepting that report?
Sir, definitely liquid biopsy is the future because the report, the TAP that we have is lesser compared to NGS. But in case we have a block, I think NGS for solid tumor on the block should be done before going for liquid biopsy. Liquid biopsy should be the last option. And yes, it is good, it is sensitive, if it gives you comprehensive report.
So that's what I was asking. If biopsy is not feasible, patient is sick. So if that report comes negative in terms of all the molecular markers, so we are okay in accepting that report, or still we should try for the biopsy?
No, sir, I don't think because
So if
you have gone for yes, it can be acceptable, sir.
it can be acceptable.
Yes, sir.
Okay. So there are some technical change things that some labs are doing and some labs are not doing.
Sir, it actually the process protocol and the availability of liquid biopsy is way different from the processing of the rest of the molecular tests that we are doing. So it is the time lag that is there. In some near future, definitely all the labs will be doing that.
Okay. 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 Right. Right. Thank you, Dr. Richa. Thank
You're
you.
welcome, sir.
Right. So after this discussion, so we'll move on to the next talk. So next session is by AstraZeneca, sponsored by AstraZeneca, and topic is turning the tides for stage 3 in NSCLC towards the curative intent. Because we know that stage 3 non-small cell lung cancers, most of the time we give CTRT and there are some residual disease, even after giving some sort of adjuvant chemotherapy 2 or 3 cycle, and then we have to wait for recurrences or again progression to start the second line sort of treatment. So there that area was vacant till few years back, I think 2 3 years back. So there are trials and now we are using in routine practice. So for this talk, I will invite Dr. Bivas Biswas. So he's senior consultant medical oncology, Tata Medical Center at Kolkata. So Dr. Bivas, over to you.
Very good evening. Thank you, Dr. Denny, for the introduction. And thank you for AstraZeneca for giving me this opportunity. So I'll share my slide in between. I hope this is visible, right?
Yes, Bivas.
Thank you. So the talk is the turning the tide for stage 3 NSCLC towards the curative intent. Yes, as Dr. Denny said, almost for a 3 decade, the radiation, chemoradiation, concurrent, sequential was the standard of care for stage 3 lung cancer. With the cure rate is definitely modest. Now with the invent of this durvalumab and subsequent study, that shows that the outcome has been improved by manyfold, and maybe sometime we can say a telling effect with the long-term responder to immunotherapy. So let's go to the introductory part. This is a Globokine 2020 data. We all know almost 70,000 new lung cancers been diagnosed in India every year. And ultimately most are going to die because of advanced stage, and lung cancer being the most common cause of cancer-related mortality, not only in India, but worldwide. So this is the expected breakup of how they present. So 10 to 15% will be a localized resectable disease, and then another 30 to 35% will be locally advanced unresectable, and 55% will be approximately metastatic. In India, I think the data says that the metastatic rate can be as high as 65 to 70%. And so almost 1/3 patient in a nutshell that has locally advanced disease, where we do treat them with CTRT with curative intent, and the question is whether we can improve their outcome or not. So multidisciplinary management is very much important for management of all lung cancer, not only stage 3, but from stage 1 to stage 4. More so in stage 3 locally advanced, because here the tri-modality treatment comes. Sometimes we give them neoadjuvant chemotherapy and a trial and to see whether they become resectable. If not, we go to sequential approach. We do treat them with concurrent CTRT. But it's important to see many aspects of a certain patient before treating them, their performance status, their histology, stage of the disease. We do PET CT MRI in each and every patient in our institute as a part of the staging, and the pathological sampling of the mediastinum. Sometimes it's most of the cases important other than the frank metastatic cases. So EBUS, TPNA plus minus endoscopy. So here involves the roles of pulmonologist, pathologist, radiation oncologist, medical oncologist, and thoracic surgeon, and definitely physiotherapists and many other the thoracic nurses. They play their each role. So it's a various facets of management of lung cancer patient, and in our institute we did discuss each and every case in thoracic DMG. So the pulmonary function, bronchoscopy, FDG PET, MRI, medicinal staging, cardiac function, and other routine performance status also is important before deciding a therapy for each and every patient. And especially in stage 3 lung cancer and unresectable cases, that this modality, the all modality of treatment comes, the medical oncologist, radiation oncologist, pulmonologist role is very crucial. The current standard of care for all stage 3 locally advanced unresectable lung cancer NSCLC is chemoradiation. We know the result is much better than radiation alone, and also the clinical trial data said that concurrent chemoradiation has a better outcome than sequential chemoradiation. At the end of the day, in 30% cases, patients are not fit for concurrent chemoradiation, so they underwent sequential chemoradiation. And the percentage vary from region to region, practice, and institute. So this is the overall guidelines. Definitely for all patients with localized from stage 1 to stage 3A, they are resectable, including neoadjuvant chemotherapy followed by surgery or surgery followed by adjuvant chemotherapy if the tumor size more than 4 centimeter and node positive. Very few single station non-bulky N2 patient may undergo neoadjuvant chemotherapy followed by surgery, but in most cases, the multi-station of the bulky N2 or NC, they are unresectable, or even in multi-station N2, even if they are resectable, that doesn't improve the outcome. So they are being treated in with chemoradiations, and definitely those who are not fit for chemoradiation, they undergo palliative treatment. So mediastinal staging is important, and there are now clear-cut guidelines for which are the patients who should undergo EBUS TPNA plus minus mediastinoscopy. So here we are discussing this unresectable N2 or the multimodal station N2 or N3. So this is the for all patient undergoing curative intent therapy with concurrent chemoradiation whenever it's feasible. If the patient is not fit for concurrent, we do try for sequential chemoradiation. Even if the pulmonary function or the performance status doesn't allow us to treat with curative intent, then sometimes patients do receive only radical-RT or palliative systemic therapy in case of very poor lung function. And there are data that many chemotherapeutic agent or protocol has been used as a part of concurrent and sequential chemoradiation. But as I said, the outcome remains not very good. Ultimately, at the end of the day, the 5-year event-free survival or the 5-year OS remains 15 to 20% in patient with stage 3 unresectable NSCLC after concurrent or sequential chemoradiation. So there has been various approach has been used to as a consolidation treatment to improve their outcome, like consolidation chemotherapy, like consolidation with higher dose of radiotherapy or gefapixant. So these are the various chemotherapy regimen used with radiotherapy in NSCLC treatment. If you see, so start with the initial cisplatin etoposide, cisplatin immunoglobulin, then we have era of pemetrexed carboplatin, pemetrexed cisplatin, paclitaxel carboplatin. So almost all the study shows comparable outcome. So whatever is feasible as per the usual practice and the comfortable of the patient and the physician and the institute should be used. In our institute, mostly we use cisplatin etoposide, and a few of the cases where we feel the patient will not tolerate cisplatin etoposide or there's a high chance of toxicity, we do use weekly paclitaxel carboplatin. And these are the sequential chemo regimen. I think we use histology-based therapy. For squamous, we use paclitaxel carboplatin. For adeno, we use pemetrexed-based therapy, platinum doublet. So these are the consolidation trial that I was discussing, used in locally advanced NSCLC with one motto to improve the overall survival or the cure rate. So consolidation docetaxel, consolidation docetaxel cisplatin. We have a big PROCLAIM study with pemetrexed cisplatin versus cisplatin etoposide. We have RTOG 0617 higher dose up to 74 degree of thoracic RT. We have consolation trial with gefitinib or anti-EGFR antibody. None of the trial failed to show any OS benefit as compared to the chemoradiation alone. That means all the consolation strategy failed to improve the overall survival in addition to the chemoradiation. So before this study came, the standard of care was only chemoradiation, be it concurrent and sequential, and then keep the patient on follow-up. And as we know that most of the patient, 80 to 85% of the patient is going to progress or recur in subsequent 6 months to 2 years of time. So traditionally, as I said, the treatment was curative intensity CTRT only. Then there came the era of immuno-oncology, and now we are discussing durvalumab. So the trial has been done with durvalumab maintenance after chemoradiation. The logic behind this trial is that the chemoradiation causes cell killing that leads to many too much of antigen production after the cell death, and those antigen is present on the cell surface as a new antigen, and there is PD-L1 overexpression. And as we know that in case of PD-L1 overexpression, there will be higher PD-1 PD-L1 interaction and energy, and if you block that interaction, then definitely immunotherapy has a higher tumor control rate. So that's why the durvalumab has been used after chemoradiation, the similar principle. So coming to the study, specific study, multi-center global study, randomized double-blind placebo-controlled study. All patients stage 3 locally advanced unresectable NSCLC who are not amenable for surgery under chemoradiations. Definitely, it was only concurrent chemoradiation, at least 2 cycles of platinum-based chemotherapy. 18 years or more, ECOG PS 0 or 1, estimated life expectancy more than 3 months, and all the tissue was collected for the biomarker analysis. So patient was randomized to durvalumab versus placebo in 2:1 randomization after completion of concurrent chemoradiation from day 1 to day 42 in case the disease was non-progressive. That means patient has to be has response to chemoradiation with either complete response, partial response, or stable disease. The therapy was for 1 year, durvalumab 10 mg per kg every 2 weeks with a matched placebo. Co-primary endpoint, PFS by BICR or the overall survival. Coming to the baseline characteristic, all were pretty matched. EGFR mutation positive was 6% in both the arm, and most patients as either 3 or 3B. PD-L1 expression less than 25% is 40%, more than 25% in 25%. So raised 40%, the status was not known because the block was not available for biomarker analysis or the tissue was inadequate. Most of all the patients received concurrent chemoradiation. 1/4 of the patient received induction chemotherapy, though that is not a standard of practice to give induction chemotherapy before giving concurrent chemoradiation, at least not at our center. Coming to the 5-year updated overall survival, the median, if you see, the median OS was 47.5 months in favor of placebo versus 29.1 months, so almost 4 years. The stratified hazard ratio for death was 0.72, that is 28% reduction in death. So this is the 5-year data, 33.4% versus 42.9%, and you see there are some tailing effect in immunotherapy arm. So clear-cut OS advantage, and this is the only strategy so far that has shown. So any consolidation strategy that has shown overall survival benefit after the concurrent chemoradiation. The first and only approved IO to demonstrate 42.9% of OS and 5 years. So almost half patient are alive at 5 years. Coming to the another co-primary endpoint by BS as a PFS. If you see the PFS, 16.91 versus 5.61. Great benefit, almost triple. The hazard ratio was 0.55. That is 45% reduction in progression. At 60 months, at 5 years, the PFS rate was 33% versus 90%, almost double. First and only approved IO to show sustained and durable PFS of 33% at 5 years. Then almost 1 in each 3 patients are still progression free at 5 years. That is phenomenal. So these are 2, 3 or 4 year, 5 year data. If you see the hazard ratio almost similar. So 5 year data demonstrate the continued benefit of PESFIX study. It did favor all pre-specified subgroup except EGFR mutation positive, though the subgroup analysis subgroup was very small, only 7%. So PFS again, all subgroup favors the use of durvalumab, except again EGFR positive. So coming to the pattern of disease progressions, intrathoracic progression is 36%, extrathoracic only 7%. So disease decreased rate of progression 45.4%. As I said, the hazard ratio for PFS was 0.55, and the majority of the progression was intrathoracic. That gives a very good local control. This is again pattern of disease progression. Time to intrathoracic progression only or death, 25% in 2 months for durvalumab versus 9 months placebo. For subsequent therapy after discontinuation of durvalumab, in durvalumab arm, 40% of patients and 50% of patients in the placebo arm receive subsequent therapy. So that means almost half of them receive subsequent therapy. Systemic therapies are most common for subsequent anti-cancer treatment in both durvalumab and placebo, because definitely most of the patient has either intrathoracic or extrathoracic combined progression that were not amenable for any local therapy. Best objective response rate by first subsequent therapy, I think this is just a subgroup analysis. But definitely conclusion are precluded given the small sample size, a large number of patients with non-available for missing data. Definitely that was not the endpoint of the study. Safety summary. Serious AE, coming to the serious AE, 29% versus 23%. Any grade pneumonitis was 33.4% in durvalumab or 25% placebo. These are definitely only radiation pneumonitis. Coming to the grade 5 pneumonitis, 5 patients in durvalumab versus 5 patients again in placebo. Discontinuation rate almost similar. And AE of special interest, that is because of IRA, definitely 67%. 2/3 of patient has immune-related adverse event in durvalumab. So again, coming to the safety summary based on the time from radiation, this is less than 2 weeks versus more than 2 weeks. That means the starting of durvalumab from the completion of radiation. If you see any grade pneumonitis or radiation pneumonitis in less than 2 weeks time, 39% versus 17%, and if you started after 2 weeks, almost similar, 32% versus higher toxicity in placebo arm. So that means if you start durvalumab as early as within 2 weeks, there is not much of increase in radiation pneumonitis if you start that earlier. And we know that a subgroup analysis shows that if you start the durvalumab as early as possible, the outcome is much better. Coming to the use of durvalumab in real world, this is specific R real world study of durvalumab in real world scenario. It's an international observation study. All patients who received durvalumab in clinical setting has been included. This is almost 1,400 patients from 290 sites in 11 participating countries. Coming to the histological subtype, is squamous 1/3, 2/3 is non-squamous. Chemoradiation type, concurrent chemoradiation was 76%, sequential was 50%. Both are included. As we know that we do use durvalumab even after sequential chemoradiation as a maintenance strategy. PD-L1 expression more than 1%, 72%, less than 1%, 17.9%. As expected, that 2/3 of patients have PD-L1 expression more than 1%. Majority of the patient was less than 75 years of age. And as I discussed, 15% required sequential chemotherapy before receiving durvalumab. Median PFS 21.7 months. In Pacific trial, it was 17 months. So the median PFS was comparable. The median duration of starting of durvalumab after chemoradiation was 56 days. Please remember that in the study, in the Pacific study, it was allowed up to 42 days, and there are many patients who did receive durvalumab within 4 to 2 weeks. But we know in clinical trial setting, many of the patients have long-term, has prolonged toxicity of chemoradiation, and they sometimes require longer time, and before starting durvalumab. So we do start durvalumab in few of the cases even after 2 months and 3 months. So the median duration of starting durvalumab in this study was 56 days. That means almost 8 weeks. Coming to the safety outcomes, AEs was 17% discontinuation rate, and the median time from Durva start to discontinuation was 2.8 months. No new adverse events was seen. All adverse events are comparable to Pacific trial. Patient with pneumonitis, moderate event was a 8.4% only. So median time to onset of pneumonitis or ILD from the durvalumab was 2.5 months, and definitely 2/3 patient received corticosteroid. The first and only approved immunotherapy to improve the OS and PFS in stage 3 patient is durvalumab, and definitely an improvement of 11.2 months of PFS from the absolute benefit. So 5-year PFS rate is 33%. 1 in each 3 patients remain progression free. And again, this similar benefit has real world evidence. 32% reduction in death. Median OS was 4 years. Safety tolerability. 15.4% treatment discontinuation durvalumab and 60.3% due to pneumonitis. Most commonly no other than the typical eye is a cough or respiratory infection, rash, sometimes transaminitis, colitis, all this. So I think I'll stop here. So both this study did show that it is effective. It can increase outcome as far as high as 40, it's crossing 40% as compared to 15% conversion. So definitely it is one of the landmark phenomenal improvement in terms of outcome with a manageable safety profile. So thank you for your patience. Denny, you are muted.
I'm unmuted. So sorry. Thank you, Dr. Bivas. So this is truly a remarkable drug, durvalumab, in this scenario which was unexplored. So Dr. Bivas, just one question to you.
Yeah.
How common in your practice are you seeing any case of tuberculosis living this scenario? So any IO drug, any indication. So how common is the tuberculosis in your practice? And are you screening for those for latent tuberculosis upfront?
So most of the cases, if the patient has past history or any symptom, we do bronchial lavage and low TB. I can recall in the last 1 year, I have almost 10 patients diagnosed with TB with concurrent with CLM. And last 3 months, we have 3 patients who has concurrent TB and could not give durvalumab. So it's not uncommon.
Any IO drug, barring the durvalumab.
We are not using any IO drug if the patient has active TB or at TB at least within the last 2 years.
2 years. If patient develops tuberculosis on IO drug, so will you stop IO drug forever?
It did happen, and we have stopped.
So, okay. Is there any guideline to stop it, or
no, there is no guideline.
If TB is controlled and disease is also controlled, well controlled, any indication, any IO drug. So,
in stage 3 setting, maybe in stage 3 setting, curative setting, maybe I will be hesitant to give and get the TB uncontrolled and patient die. But in a stage 4 settings, sometimes we are compelled to do. So I give at least a few months of gap, get the ATT and the TB control, and then resume if there is no other treatment strategy exists. So sometimes I bridge over with chemotherapy.
Thank you, Dr. Bivas. So after this talk, so I would invite Dr. Bhuvan Chugh, his consultant again, Max Hospital, Saket and Gurugram. So there is a panel discussion on this small cell lung cancer, extensive stage. So as of now, till few years back, we were having only chemotherapy drugs, and now IO drug has come into this scenario. So for discussion part, so I would invite Dr. Bhuvan Chugh. So over to Dr. Bhuvan. So you can invite your panelist.
Hi, sir. Good evening.
Good evening.
So I think I have a list of panelists. One second. So Dr. Ankur Vashne, are you there?
Yeah, hello, sir. I'm here.
So I think thank you for being there and thank you for taking out time today evening. And Dr. Jyoti, are you there? Dr. Jyoti, are you there?
Yes, sir. Ma'am is muted, sir.
So I think Dr. Bivas Biswas, did he just leave or something? He was there for a minute. I just saw him leaving. Is he there, or should I just leave it be? Garima, can you confirm, please? And Dr. Deni Gupta, obviously, we see him and he's been.
Yeah, I'm here.
So I think I'll start. It's a panel discussion on management of extensive stage small cell lung cancer. Thank you, Dr. Deni, and thank you, AstraZeneca, for this opportunity. And it's a very interesting panel here. It's a very interesting case here, rather. And moving forward, I think the way we're going to change, it's almost changed the way we manage our small cell lung cancers. And however, it's not there as yet. Yeah, the median survival is still here at max 8.5. We know that the small cell lung cancer, it tends to respond very well to the chemotherapy the first 3-4 months, and then it just springs back as if it just come back with a vengeance. Anyway, moving forward, we have a 62-year-old gentleman who has been a smoker, and it's very rare. It's almost impossible to find small cell in non-smokers. He is presented with increasing shortness of breath. There's hemoptysis. There's weight loss, and the patient's primary care physician has found there's a liver palpable. There's a massive enlargement. There is 3 to 4 times increase in there's a transaminases. The CT scan has been done at his first point of care, and that show a left lower lobe nodule, mediastinal lymph nodes are there, and there's a massive hepatomegaly. Somebody has done a biopsy, and it is also suggestive of a small cell histology. So moving forward, I'll start with you, Dr. Deni. What's your diagnostic workup? Would you want to repeat the biopsy from anywhere? Would you want to check for the mediastinal lymph nodes, or would you want to check from the liver? Well, how would you want to proceed forward there?
So can you show me previous slide, Dr. Bhavan? Yeah. So CT, I believe only CT chest was done.
Yes.
And right. So
yes.
And biopsy was done from which part?
So I think it's not mentioned, but I presume it must be from the liver. But anyway, let's presume that if no biopsy has been done, possibly what would be your...
Right. So if we are dealing with such type of case and a CT guided lung biopsy has been done, which is the usual scenario. So it is small cell lung cancer. So first of all, I would do the whole body PET CT scan for the staging workup along with brain MRI upfront, because we know that it is very common in small cell particularly, and even in non-small cell if they are a molecularly driven tumor. So I would be liking to do the PET CT scan and then straight away biopsy from the lung, preferably. If it is not feasible, if it is a hilar mass lesion, so we can go for the bronchoscopy, and we can go for TB-LB sort of thing, transbronchial lung biopsy. And I think mediastinal staging I will not do. In those cases where there is already metastatic in the liver or bone metastasis or somewhere else. So if we are dealing with the earlier stage, and we are skeptical about the mediastinal staging, so there only I would go for the mediastinal, otherwise not. So these are the sequential workup.
So let's presume the liver is not there. Moving forward, if it's only the lung lesions and the mediastinal nodes, would you want to stage the lymph nodes, especially considering there will be a limited stage? They're going to obviously include that in the radiation field. That's how the staging is defined, right? The veteran.
Yes, correct. If we are dealing with
limited stage,
clearly that is if it is imaging is showing the lung mass lesion and there is a mediastinal lymph node hilar either on the ipsilateral side or contralateral side, so then I would definitely like to confirm the pathological by bronchoscopic evaluation, or if as per the location, I think there are some stations where by bronchoscopy chest physician are not comfortable in sampling, then obviously mediastinal sampling will be required in those scenarios.
So the question which I wanted to raise, Dr. Varshney, if you are there, generally in a non-small cell lung cancer, whenever you're defining your field of radiation, so I'm talking about a multi-station N2. So if it's a non-small cell lung cancer, when you're defining your field of radiation, you want to do a EBUS and you want to stage your lymph nodes so that you can map your radiation field and give a radiation according to the nodes involved. There's a 25% plus and there's 25% minus. The nodes which appear positive on the PET are negative, 1 in 4, and then the one which don't appear on the PET are positive 1 in 4. So what I'm saying is, does that same rule applies to your clinical practice in small cell, or do you generally not stage a patient?
So generally, small cell, I find a very limited subset with limited stage. Maximum, they are usually metastatic only. But if yes, if we found a stage 3 patient coming to and planned for CTRT, then we follow the same concept.
So what you do is you generally map the mediastinal nodes.
Map the mediastinal nodes.
Interesting. Anyway, so I think because as far as this thing is concerned, even if you have a supraclav also, then also it is a part of the limited stage. So anyway, I think moving forward, we need to get this clarity from the radiation oncology colleagues, whether they want to map, whether do they cover these lymph nodes in a limited stage, or they do
so Dr. Bhuvan, if it is PET positive, so I think many radiation oncologists are taking with the involved node if they are actually with the higher SUV, and if this is supraclavicular on the opposite side, I think then that may not be covered as a limited stage.
Do you agree, Dr. Varshney?
Yes, sir, I agree with that.
Okay.
Mostly, if lymph nodes are positive on PET CT scan, and further sampling is not needed.
Even in the non-smell, you do that?
Usually. I think there is a study from AIIMS that is published, the EBUS comparison with PET CT, and they found that value is significant. There is no difference.
How much is the significant value? Because it's a general rule in my. I'll obviously take it up with my radiation oncology colleagues tomorrow.
Definitely.
But I don't think, because it's a common practice for us to generally map the, unless we're not talking about. So I understand if it's a large node, which is obviously definitely positive. We're talking about simply FDG EVIT nodes. Anyway, for a non-small cell, I'm certainly clear that only the FDG positivity. Obviously, the look of the node matters a lot. If there's a large node, you generally it's given that it'll be positive. For a node which is around a centimeter, has a FDG avidity of, let's say, 3, 4, 5. I would rather have in a non-small at least, have a EBUS and define the radiation field, because I think the toxicity will change a lot with that.
I think, Dr. Bhuvan, you're right. I think cutoff is usually in our practice. We keep cutoff 7 to 8.
Yeah,
although sometimes nuclear medicine guys say this is SUV stupid uptake value. But still we take cutoff of 7 to 8. And you are right if it is 3 or 4. So we have to take with a pinch of salt whether it is involved or not. So definitely I agree we should go for some sort of sampling from that area.
And so moving forward, you obviously define them as limited stage and extensive stage. And so moving forward, the patient is a 62-year-old smoker. He obviously has liver positive, and the presence with increasing shortness of breath, hemoptysis, weight loss, and then there's a massive enlargement of liver. It's an extensive stage disease. MRI is thankfully clear. And moving forward. So what is Dr. Jyoti, if you're there, you generally tend to prefer cisplatin or carboplatin for an extensive stage?
Hello. Hi, Dr. Bhuvan.
Hi.
So your question is choice of platinum in EP regime, cisplatin. I try to give cisplatin because we all know that small cell carcinoma, it spreads to brain very fast, and cisplatin has some kind of penetration. So I prefer cisplatin if patient is eligible for cisplatin.
So your preference is for cisplatin.
Yeah.
Dr. Ankur, you have a particular fetish for either of the platinums, or it's primarily based on the general condition of the patient? Dr. Ankur, are you there? So Dr. Deni, what is your take on this? Choice of platinum?
Surely, Dr. Mohan, I think cisplatin will be my preferred choice because if patient is having like some neuropathy because of diabetes, underlying diabetes or cardiac problem, and there and obviously performance status. So there I may tend to choose carboplatin over this rather than using the cisplatin. Otherwise, cisplatin is my first choice.
Hello?
Yeah.
Sir, sorry, I lost the contact. Sir, it's preferred is cisplatin only, but if I found general condition of the patient is not well, then I prefer carboplatin.
Why all of you saying preferred is cisplatin? I'm generally asking. There's a data to the contrary. It's both equal are there. I mean, when you consider an extensive stage disease, aren't both equal? Dr. Deni, would you want to? Why would you prefer cisplatin? I'm just really asking.
I think you're right, but like we have seen that for urinary bladder at least. So there is a data which says that cisplatin is better than carboplatin.
No, even for the limited stage, in a limited small cell, yes, cisplatin is obviously certainly better than carboplatin. But extensive stage, Dr. Ankur, do you think there is enough data to suggest both are equal or?
Yeah, I feel the data is enough, but what we have followed in our clinical practice, I think update is still not there. And we prefer is because patient has to come ultimately for etoposide for 3 days.
So my thing is that if I'm giving carboplatin, I obviously, you end up preferring cisplatin for somebody who's fit. But my only thing towards carboplatin is it's easier to give, and then, you can tailor it more towards the kidney function. Because
I think, Dr. Bhavan, we all have grown up with the understanding that cisplatin is slightly maybe better than carboplatin. You're right, in extensive stage it hardly matters, but our intention, there's a reflex action to use the cisplatin, and then you're right, you're not wrong in using the carboplatin.
No, I'm just being.
I got it. But reflexly, like there is no data as such, I think, but we think that cisplatin is better than carboplatin in outcome.
Number of cycles you generally choose 6 or you choose 4? What's your standard practice?
So standard practice like literature 4 to 6. So I tend to use 6 cycle in my patients with extensive stage.
Dr. Varshney, what is your choice, 4 or 6?
So I usually prefer 6 cycle complete.
This is with IO, without IO?
This is without IO.
With IO?
With IO, 4 is my recommendation. So my trial is with 4 cycles only. So in that condition, you prefer 4 cycles.
So what I'm saying is, do you give into your? So obviously, once you, small cell, once you've done 3 cycles, the patient responded very well. And do you give into your urge to do 3 more cycles, or you stop at 4th?
Sir, in case at least 4 cycle has to be given.
No, I'm 4 to de na. I'm thinking, I'm asking you, 6, do you go to 6 or you stop yourself at 4?
If a patient is not there for any immunotherapy, because ultimately the patient will relapse. So we are not opting any treatment. So we complete usually.
No, I'm talking about with IO. So this is without
IO. With IO 4 cycles. With IO 4 cycles, and then we put on maintenance with IO.
Dr. Jyoti, with IO, your choice of cycles, 4 or 6? I think we lost her. Anyway, so I think we all understand that in today's world and era, I think if the patient can afford, I don't think anybody of us will not give immune checkpoint inhibitor unless it's contraindicated, and there's a good amount of data for it, and I think you don't obviously there are toxicities to it, but then considering that the patient has an extensive stage small cell lung where possibly any added therapy, so it's been called as a recalcitrant cancer, where there's hardly. So if you look at the DEVITA chapter, I think there are only 2 pages which says what works, and I think there are 4 pages which says what doesn't work. So I think obviously when with the IO coming in, I think it's obviously been some light in the end of the tunnel. And so in 2022, I don't think there's anybody of us who will not choose ETO, platinum, and IO. Dr. Ankur, would you choose otherwise, or that's your go-to regimen?
Sir, it's only depend upon the pension's status whether he is able to afford it or
We're
not.
obviously talking about somebody who can afford it. मतलब कोई नहीं afford कर पाता तो
यूएई afford करेंगे.
So anyway, so I think there are two drugs to it. There's a durvalumab and there's a atezolizumab. Do you have any choice, Dr. Deni? Do you have any favorite as before we move forward?
Although data is almost similar, if you see the response rate and outcome, so both drug have done very, very well, equivalent response rate and everything. But still, I have my intention to use durvalumab upfront rather than atezolizumab. So my experience with atezolizumab is not very good in terms of response rate. So I tend to use prefer to use durvalumab.
Dr. Jyoti, what is your choice of IO?
I think I agree with Dr. Deni that we have got a good response rate with both the drugs. There is no such preference. I am using both of them, atezolizumab also and durvalumab also. So both are equal for me.
So as we understand that, I think small cell, the problem is the rapid comeback. And, as we move along the number of cycles, obviously the number of patients who receive the subsequent lines of therapy are very, very small. So both the drugs have been approved in the first line in a IO chemo combination. They both are given 3 weekly, and then there is the maintenance is 4 weekly for durvalumab, and it is 3 weekly for atezolizumab. And as pointed out by Dr. Varshney, both the regimens use 4 cycles of chemotherapy followed by maintenance IO. So as you see it, there are obviously three combinations which end up forming. There is Eto Carb Durva, Eto Cis Durva, and Eto Carb Atezo, which goes to say that in IM Power 150 it was they could only use, there was no cisplatin given, it was only Eto Carb and Atezo. So I think the panel is clear that most of the time they end up using EP Durva. However, there's an option to use EP Atezo also. So just to give the, I'm sorry, it's not IM 150, it's a 133. So if you look at the difference of the study design, what was different was in the patient, in the Caspian arm, the PCI was allowed in the control arm, and PCI was allowed in the experimental arm. It was excluded in the experimental arm. The patients who underwent durvalumab, they did not receive PCI. And there was up to 6 cycles of chemo in the control arm they were allowed in the Caspian arm, and also the cisplatin was allowed. So there were 3 essential difference in the Caspian trial as compared to the IM Power 133. The PCI, which was excluded in the, so the patients were not allowed to undergo a prophylactic radiation. Up to 6 cycles of chemo in the control arm were allowed. They were not allowed in the atezolizumab trial, and the cisplatin was also allowed. So this is the difference at the end of. So what is also available is the 3-year follow-up data, which is obviously not available for the atezolizumab. So at the end of 2 years, there was an improvement of almost 9% in terms of overall survival, which I think, considering a small cell lung cancer, if somebody tells me that almost one out of the four is going to be living at the end of 2 years, I'll probably be happy. And possibly 17.6 or basically around 18% of the people are alive at the end of 3 years. And coming to the control arm, there's hardly, so possibly 6 out of 100 to 18 out of 100, which is a remarkable difference if we talk about the improvement in overall survival. So that's what has been there. So Inflinzy, which is the durvalumab, it's a well tolerable drug. It obviously improves the overall response, overall survival. And it's the absolute improvement may just be 12 months in the terms of median, but I think we all understand, and as I spoke in my last talk also. So whenever we're using IO, it's not about, it's possibly not about the median improvement. Yes, it does cause a median improvement in overall survival, but it is about picking up those patients which, so essentially we are talking about a disease in which there is no survival. Now, if you're able to pick up this extra subset of patients in which there is an extended improvement in overall survival, I think you have done your job, or possibly the drug has done its job. So as I told you, IM Power 133, at the end of 2 years, there's a data up till 2 years, there's a 22 months, 22% 2-year survival. And it's almost similar in the Caspian arm, Caspian trial. However, there's a 3-year data also. So I think same thing. So this patient receives systemic therapy, has 4 cycles of cis-eto durva, has near complete CR. There's a resolution of the liver lesion, which is obviously expected in the first line. He's put on maintenance durva, 4 weekly maintenance therapy, which is different from the 3 weekly therapy, which is given by atezolizumab, and it undergoes serial scans every 3 months. So, coming Dr. Vaishnav, you do PCI for everybody, or you are taking a distinction in these today's world and era?
So routinely, what we studied earlier was that PCI has to be given in a patient who has responded. So now that with the data coming of durvalumab, where some patients were excluded, I usually discuss with the patient first.
I think not some, but then none of the patients in the durva arm underwent PCI. But yes, so Dr. Jyoti, your take on this? Do you routinely advise PCI? I lost Dr. Deni. I possibly it's the same thing. So basically, historically, PCI, as Dr. Vaishnav also commented, that historically, possibly everybody who had extensive stage small cell lung, we obviously wanted them to undergo PCI because almost 90% of the patients, they did develop a brain metastasis, which possibly was more catastrophic. Now, however, the divergent data is there, and there's a prompt reassessment happening. There is availability of SRS, and we are obviously more aware about the adverse effect of a PCI. So I think it's a decision which seems to be individualized now. So as of now, the statement is there's a paucity of data as far as the integration of PCI and immunotherapy is concerned, and the patient with extensive stage small cell lung cancer without brain metastasis on MRI, I think PCI can be omitted, and a regular brain MRI may help you understand how do you want to go forward. So, Dr. Deni, your take on thoracic RT for an extensive stage small lung cancer?
So, I think I can recollect only one of my patient in last few years only where I have gone for thoracic RT because all the metastatic sites were clear. And I have gone for our radiation oncology, I have gone for PCI as well as thoracic RT. So many of the patients, we are not opting for this thoracic RT, but if extra thoracic diseases are well controlled or in fact near CR sort of thing, then obviously we go for thoracic RT.
Which itself is very rare. So let's be very frank. It's obviously rare to...
One out of 10, 20 patients. So, but yeah, I've gone for that in one of my patients.
So again, I think the statement is also very clear. There's greatest benefit of thoracic RT is limited to patients with residual thoracic disease after systemic therapy with less than or equal to 2 metastases. And when it comes to immune checkpoint inhibitors, there's obviously a paucity of data. So, as we do more and more radiation so what I've started seeing is as we are utilizing more and more SBRTs for the oligometastatic sites, there are these systemic adverse effects which tend to happen. And, you think that you're doing possibly my radiation oncology colleagues thinks that he's doing a SBRT and there's going to be no systemic toxicity. What I've found is there's a lot of cytokine release, and most of these patients, they take a longer time to have for a myelo recovery to happen. I don't know, it's possibly my experience or somebody who's undergone a SBRT to a non-pelvic site also takes a longer time for a myelo recovery to happen, possibly because of cytokine release. There's a prolonged myelosuppression. So when you move on to the subsequent chemotherapies, they tend to have a longer the duration of cytopenias is longer, is what I felt. And I don't think any RT is without any systemic adverse effects. There is obviously some degree of systemic adverse effect is there, especially when you're using it with the agents such as gemcitabine or carboplatin, in which obviously there is the thrombocytopenia has a big problem with these agents. And I think that's where it kind of causes a problem. So again, coming to the NCCN guidelines, it does suggest that you can consider PCI and thoracic RT if the patient has extensive stage disease. But then I think all these data are obviously the guidelines are derived from before the IO era, and I think coming to the IO era, we are very clear that somebody who has a PS 0 to 1 or equal to 2, you possibly may go ahead with ETO platinum with IO and for 4 cycles and followed by IO maintenance. So the patient is on DUVA maintenance as on surveillance for MRI brain. So again, if the patient had, Dr. Jyoti, let's say the patient had a brain metastasis diagnosis, do you consider or do you do SBRT for everybody to begin with, or it's only for the symptomatic brain metastasis? Do you end up doing SRS?
I prefer RT in patients who are symptomatic, like symptomatic brain mets.
I'm talking about asymptomatic. For asymptomatic ones?
No, I will go ahead with chemotherapy first, and if in any case patient becomes symptomatic in between, then radiation will be added. Otherwise, we'll finish off chemotherapy first.
Dr. Ankur, what is your take on it?
Sir, in asymptomatic patient, I prefer chemotherapy first.
And the reason being?
Usually,
are you not scared that the brain PD will happen?
Isolated, usually, sir, the disease is chemosensitive. They usually will respond. It's very rare to have a progression on chemotherapy.
Fair enough. I take your point, and also I think the other point to me is that possibly 2 weeks, even a week, 10 days delay in such a patient that leads to a rapid deterioration in performance status. Once the performance status deteriorates, you possibly lose that window where you can do etoplatinum.
Curative intent.
Anyway, so what was seen was the patient who had brain metastasis at baseline. There was obviously the overall survival was lesser, but the advantage of doing a Durva was more. So the hazard was it's 0.69 as compared to 0.74. Somebody who did not have brain metastasis, and as expected, obviously somebody who had a brain metastasis, the overall survival was lesser. But what is to be seen is that the advantage which possibly Durva is giving or IO is giving is better. So what has recently happened is that what has happened to me is so all these patients who tend to do poorly, for example, a triple negative breast who's PD-L1 negative, so there's obviously a definite advantage of doing immune checkpoint inhibitor, and they generally provide you a good advantage there. And that's what we've seen in a forest plot also, that somebody who had this is obviously the IMpower 133, which I think there's the way this trial was designed, there's a bit of an issue with that. But then yes, the patient who had brain metastasis in which the placebo did better. And moving forward, the patient is on durvalumab maintenance, and after completed 8 cycles with no evidence of progression of serial scans. So what is obviously also different is that there is a once in 4 weeks maintenance with durvalumab as compared to once in 3 weeks. And I think we all have an answer for this. For somebody who is performance status 3 to 4, we end up doing best supportive care. And somebody, obviously the performance status does make a choice. Dr. Deni, would you choose irinotecan for somebody who has a poor performance status, or possibly any other agent other than the standard carbo-eto or cis-eto?
You're asking first line, no? First line with
a poor PS. Let's say the patient is poor PS2. Would you end up doing anything else?
No. In those scenarios, sometimes I have used weekly basis. So although it's 3 weekly is the standard platinum etoposide, but I have used weekly in some of the patient where poor PS is there, at least for 1 or 2 cycles, but not irinotecan.
Dr. Varshney, have you used? Sorry to interrupt, sir. Please.
Yeah.
Same, sir. I have used low dose carboplatin only, AUC2, and have seen improvement with this. Not use irinotecan.
Any biomarker you have evaluated in a small cell?
Not much experience regarding in this.
Anyway, so I think to summarize, we have. I think there's obviously the IUs have become the standard line in terms of small cell. I think it's primarily because of the poor prognosis and poor biology this disease carries. It's obviously a nightmare to treat it. You will possibly have a very good response in the first 2-3 months, and then the way it comes back, it obviously breaks the heart of everybody. And I think moving forward, looking at the once in a month maintenance, which obviously Durva provides, it's obviously going to become the preferred agent or preferred IU when compared to atezo. I think that's from my side. Thank you.
So just one question to you. If extensive stage brain metastasis is asymptomatic, will you refer to radiation oncologist or not?
Extensive stage brain metastasis, single or multiple?
asymptomatic brain metastasis, like we were discussing in.
No, I would not. My point is,
not
if
refer to
there
repeat.
are more than 5-7, they'll do a whole brain RT. If there is a whole brain RT, the patient will never survive to come back to me. As in, after 3 weeks, 10 days of brain RT, a week, 10 days of waiting. After 2 to 3 weeks of a small cell, I don't think he will have a performance status to do anything. If it's a single odd brain met, anyway, I'll obviously prefer to give systemic therapy because it will take care of it. I think the only problem is if there are 3-4 of these brain metastases. That's the only thing which I'll be a little concerned about, especially if one of those brain metastases is it infratentorial or is it in a motor cortex where I feel that it may throw up. So that's the only problem, that's the only way I'll possibly have a discussion with my radiation oncologist as to this is a very critical area. It's just infratentorial. It may lead to some degree of it, possibly a discussion, but not a referral.
I think even for asymptomatic, we have to take them into loop before deciding not to go for radiation.
Agreed, sir.
Right.
Okay, sir.
So thank you, Dr. Bhuvan, for a wonderful discussion, highlighting the important points which we would think it's very easy, but certainly there are some points which we need to keep in mind before deciding the treatment plan of action for any malignancy for whatsoever. Thank you. Thank you.
Please.
So thank you all the panelists. So next, after this panel discussion, next talk is by me only. So, so now we are going to, I'm going to speak on recent abstract of clinical application in GA in lung cancer. So, so I will be going through the 4 abstracts. One abstract is about, again, extensive stage small cell lung cancer, which we were discussing just now. So newer drug about that. And the second abstract will be about a neoadjuvant setting in the lung cancer, that is NeoScore trial. And third abstract will be about pembro in the adjuvant setting for lung cancer, that is PEARL trial. And last, 4th one will be about the radiation in the small cell. So which dose, because that is also not clearly defined in literature. So all these 4 abstracts I am going to present one by one. Just a minute, yeah. So my first abstract is Skyscraper 2. So primary results of phase 3 randomized double-blind placebo-controlled study of atezolizumab plus carbo plus etoposide with or without. This is a new drug that is Tyra. That is short form is Tyra. Tyrogolumab. So in patient with untreated extensive stage small cell lung cancer. So as of now, we all know that atezolizumab is the standard of care with etopo and carboplatin. So this is a newer add-on therapy which was tried in this phase 3 Skyscraper 2. And we have discussed IMpower 133 trial in previous discussion. So TIGIT is the newer novel inhibitory immune checkpoint, which is present on immune cells in many cancers, including small cell lung cancer. So it is highly correlated with PD-L1 expression. So Tyrogolumab is a human anti-TIGIT monoclonal antibody that may synergize with other immunotherapies such as atezolizumab or so to amplify the anti-tumor response. With this hypothesis, this study was done. And so this is a study where they have included the patient first-line extensive stage small cell lung cancer with no prior systemic treatment for extensive stage, and patients with treated or untreated asymptomatic brain metastases were considered. So roughly 500 patients were taken into this trial, and 1:1 randomization with the experimental drug, that is Tyra, along with these 3 drugs. So 4 drugs were in one arm, 3 drugs in other arm. And after induction of 4 cycles, then maintenance of both arms were received, Tyra plus Atezo versus only Atezo. And patients were treated until progression and or loss of clinical benefit or unacceptable toxicity profile was there. So there were some endpoint, co-primary endpoint, primary analysis where there was without any brain metastasis. So full analysis set they have considered into the brain mets also. So this is the demographic profile in both arms. Age, male, racial status was well balanced in both arms, and brain metastases were also considered about 6% in both arms, and they were well balanced. Although PFS in primary analysis set where brain mets were not considered into analysis. So we can see the curve and median PFS is 5.4 in the experimental drug, 5.6 in the placebo. There's no difference found. And the same was the story with the interim OS. No difference in this outcome. Even in the full analysis set where they have taken into the account all the brain metastases treated or untreated, even there also there was no difference found in the PFS or OS. Curves were almost overlapping. And if you see the subgroup analysis, so all the differentiating point, if you see brain mets treated or untreated, so bar we are seeing it is on the center line. So it's not favoring any of the treatment modality. So this is also unremarkable. So for brain metastasis also subgroup analysis, median OS 11.7 with the Tyra combination, 10.6 with the placebo one. So this is almost similar. Objective response rate also was slightly higher in the Tyra. CR rate also higher little bit, but not good significant number. And if we talk about the adverse event profile, so grade 3 or 4 adverse event was seen in both 64%. I think 60, yeah. And the serious adverse event was seen in 43 in both arms. So they are also similar in both arms. And although anemia, neutropenia, and constipation was slightly more in the Tyra arm. So conclusion of this study was that addition of Tyra to this triple drug, they did not provide any further benefit over this triple drug combination in untreated extensive stage small cell lung cancer. And although it was well tolerated, but response was not seen in a positive direction. So this study, Skyscraper 2, will continue to the planned primary OS analysis and biomarker analysis are ongoing. Based on these data, targeting TIGIT in this scenario at least doesn't appear to be therapeutically relevant. Although in other malignancies like esophageal cancer, I think trials are ongoing and it might be showing positive results at least in non-small cell lung cancer or esophageal cancers. So second study was about the neoadjuvant scenario in the resectable non-small cell lung cancer. And here dilemma part was that whether we should give 2 cycle versus 3 cycle of any neoadjuvant drugs. So here they have tried the newer drug, that is sintilimab. Basically, it was the, I think, Chinese study where they have combined sintilimab with the platinum doublet in resectable non-small cell lung cancer. As I said, neoadjuvant immune checkpoint inhibitor plus chemotherapy have shown promising efficacy as a neoadjuvant, no doubt. But a dilemma was that whether to use 2 cycle or 4 cycle before going for surgery. So that was debatable. And this was addressed in this study. So sintilimab is a monoclonal antibody against PD-1, which have shown the favorable MPR, that major pathological response in single agent setting in earlier trial. So after this, that trial was done along with chemotherapy. So before conducting this trial, these were all studies which have been conducted so far for this scenario, which have shown good MPR, major pathological response up to 60-67%, even 83% with nivolumab plus platinum doublet for 3 cycles in stage 3A. So this was the trial design for this is NeoScore, and it was histological confirmed stage 1B, 3A, resectable non-small cell lung cancer. All patients were treatment naive and good performance status. So sintilimab, experimental drug, 200 milligram day 1, along with chemo doublet, platinum doublet, 3 weekly interval for 2 cycle, and then sintilimab again for 3 cycle. So idea was just to decide whether 2 cycle is enough or we should go for 3 cycle IO combination with a chemo doublet. So after that, surgery was done within 4 weeks after the last dose, and then obviously adjuvant treatment was done for 1 or 2 cycle, and then maintenance treatment with sintilimab. Primary endpoint was major pathological response rate. Secondary endpoint was PathCR, 2-year DFS rate. And baseline characteristics were well balanced in both arms, whether 2 cycle or 3 cycle. Smoking status was also balanced, roughly around 60% patient was current or former smoker in both arms. And adenocarcinoma were there around 35 to 40%. Squamous were there in although more in number, roughly 55 to 60%. and PDL1 status was there, less than 1 or more than 1. It was also well balanced in both arms. So we can see that 3 cycle have shown more response rate in terms of MPR, 41.4% as compared to 26.9% with the 2 cycles. And although p-value was not significant, so 3 cycle treatment had presented a 4.9% increase in PAT-CR in comparison to 2 cycle with a p-value of 0.660. And similarly, radiological response was also seen if we see the 2 cycle versus 3 cycle. So there was almost 50% response rate with the 2 cycle and 55% response rate with the 3 cycle. And here p-value was significant, 0.70. And if we see the subgroup analysis, particularly for clinical stage, so we can see that stage 1B to 2B bar is on the center line. On the other hand, stage 3A, it is favoring the 3 cycle. So clearly, all the most of the parameters are favoring the 3 cycle in at least in the slightly advanced, locally advanced stage. So if you see the tumor response by histology, squamous and non-squamous. So non-squamous is showing definitely better outcome as compared to squamous carcinoma. So based on PDL1 status, it is also not clearly defined in this study. And surgical outcome, if you see all the variety of surgery, segmentectomy, lobectomy, bilobectomy. So 3 cycle treatment did not increase any surgical risk in any of the scenario or postoperative complications. So 3 cycles chemotherapy as well as IO drug, this was well tolerated with good surgical outcome. So treatment related adverse event also, anemia was there, decreased TLC count, thrombocytopenia. So all these side effects, although more with 3 cycle, but well tolerable in 3 cycle as compared to 2 cycle. So conclusion of this study was that it is a first randomized study to compare the 2 cycle versus 3 cycle in the neoadjuvant setting. So I think 3 cycle neoadjuvant treatment achieved a better, higher MPR rate as compared to 2 cycle and was consistent across most of the subgroup. So MPR rate was impressively higher in the squamous carcinoma as compared to non-squamous. So this data definitely suggests that more cycle, at least 3 cycles should be given before going for surgery. So third abstract which I am going to explain was the PULSE study. And this is about the adjuvant setting of non-small cell lung cancer regarding pembrolizumab versus placebo for completely resected early stage non-small cell lung cancer in subgroup related to surgery, disease burden, and adjuvant chemotherapy use. So eligibility criteria were stage 1B, 2, 3A, and complete surgical resection and provision of tumor tissue for PDL1 testing was kept. And so there were 2 arms, 1:1. Pembrolizumab standard dosing 200 milligram 3 weekly, vis-a-vis placebo 3 weekly was given. So primary endpoint was DFS in overall population and also in TPS more than 50% population. Secondary endpoint was also seen in various different cutoff of TPS, and downside they have given the various characteristic about the profile about the pembro versus placebo. So they were well balanced about the smoking pattern, histology pattern, and even stage pattern, and EGFR and ALK translocation also. So if you see the outcome primary results, DFS was, we can see that this curve 18 months rate is 73% as compared to 64. So 10% benefit in the DFS if you see the overall population. But if you see the, as per the PDL1 cutoff, more than 50%. So this difference is not there, almost similar outcome, although curves are separating after that. So there may be benefit later on. So if you see the OS, OS benefit is also not seen in this trial. And various subgroup of surgical setting like bilobectomy, lobectomy, pneumonectomy, all of these settings are showing the response in favor of pembrolizumab as compared to chemotherapy in the adjuvant setting. So if you see that this curve, pembrolizumab is better in the nodal status if it is 0 to 1, but in nodal status 2, that is not showing any advantage over and above the placebo. So conclusion of this trial that it supports the benefit of adjuvant pembrolizumab at least for stage 1B where tumor size is more than or equal to 4 centimeter or to stage 3A NSCLC following complete resection. And if recommended, then adjuvant chemotherapy can also be considered. So last abstract of my talk is on the radiation, because in small cell lung cancer limited stage, so clearly there is no defined guideline whether we should use the radiation in the OD fractionation or twice a day fractionation. So this was one of the study that is called GB30610, where they try to compare the quality of life in both scenario and as well as the outcome. So questionnaire in the form of FACT trial was kept, and various other questionnaire was kept to the patients, and at different time points they were analyzed. So 417, roughly 417 patients were taken into consideration. And if you see the results of this trial, demography was although like 45 gray fraction versus 70 gray fraction. In 70 gray, they have given the once a day dosing, and 45 gray, they have given the twice a day. And it was completed in early, although 70 gray was given, I think, 6.5 to 7 weeks. So demographic profile was well balanced in both arms. Results, we see that this questionnaire FACT was showing that there was a worsening. There was a less worsening at week 3 in the in the red curve, which is for the 70 gray arm. Although it is crossing over there after 3 weeks, so results are ambiguous, showing that they are worsening less in OD dose at week 3, but greater at later point of time at 12 weeks. So the result of questionnaire was mixed in the earlier analysis and later analysis. So treatment convenience score was seen. So it was very convenient to give in 45 gray, 15%, and 19% in 70 gray. So convenience level was also assessed. So both concluded that both like OD dose or twice a dose of radiation were well tolerated, and better quality of life score at 3 weeks, but worse at 12 weeks. So once a day arm was perceived to be less inconvenient. So that was the outcome in this study. But I think in most of our practice, we are following the once a dose 65 or 70 gray over a period of 6.5 to 7 weeks time. So I would stop here my talk, which was about abstract for the lung cancer. And yeah, so I think we have about to conclude. So just to summarize our CME today, so earlier we have discussed how the role of nivolumab is evolving in the esophageal cancer, stomach cancer, esophageal gastric. So we can combine these nivolumab with the chemotherapy drugs in the upfront setting, as well as in the second line, it has been approved as a single agent. So that was a scenario for IO drug in the GI cancers. And then we have discussed about the molecular profiling, EGFR ALK. We are all versed that panel is broadening day by day. So we should try to get the NGS panel as far as possible to get the maximum number of driver mutation, because we know that IO drugs are ineffective if there is underlying driver mutation found in NSCLC patients. So therefore, our understanding is that we should go as far as possible broader and broader panel for NSCLC patient. And then we discuss about the small cell lung cancer as the Caspian study, Pacific study, how durvalumab have shown remarkable difference in the adjuvant setting after CTRT. And even for the Caspian trial, we have seen that stage 4 setting, it has shown very good result. And longer term follow-up, 3-year follow-up is there for Caspian study. So I think we are well comfortable in using the durvalumab even in the stage 4 small cell lung cancer. So all these feedback which we have learned from today's CME, I would like to conclude over here. Today's CME. Thanks for all the participants, for all the presenter as well as the attendees. And thanks for the AstraZeneca, BMS, Lal Lab, and Fresenius Kabi for participating. And at the end, thanks, Dr. CME to be organized by Mr. Tarun. And thanks all the attendees. In the end, thanks. So, Dr. Garima ji, should we wind up?
Yes, sir. Thank you, sir. Thank